Good morning, everyone. I'm Dr. Ala Musmah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about dysmenorrhea. So, what we want to discuss today? The definitions, epidemiology, risk factors, pathophysiology, etiology, diagnosis, and lastly, the treatment. So, let us start with the definition. Dysmenorrhea means pain related to menstruation sufficiently severe to interrupt the patient's daily activities. Maybe interrupting the adolescent girl from going to school or a woman from going to work and so on. Dysmenorrhea can be primary or secondary one. What is the difference? In the primary dysmenorrhea, there is lower abdominal pain occurring during menses, which is not associated with other disease or pathology. While secondary dysmenorrhea, occurrence of lower abdominal pain also in response to underlying pathology such as endometriosis or adenomyosis, which are common causes of secondary dysmenorrhea. Okay, what about the epidemiology? Really, the prevalence of dysmenorrhea is high and wide range, between 16% up to 91% in women of reproductive age. But the severe painful one observed in 2% up to 29%. The prevalence of dysmenorrhea is 80% in adolescents. 40% of them had severe dysmenorrhea. Dysmenorrhea is associated with significant impairment in quality of life, between 16 to 29% of women. Furthermore, 12% of the monthly school and work activities are lost due to absenteeism because of dysmenorrhea, as I mentioned before. The symptoms associated with dysmenorrhea include nausea, vomiting, bloating, diarrhea, constipation, irritability, indigestion, tiredness, headache, dizziness, low back pain. Specifically, these usually associated with the primary dysmenorrhea. Okay. So what are the risk factors? Age may be risk factor. Age between 13 to 15, perimenarchal age. Earlier age at menarche. Smoking, attempt to lose weight, higher body mass index, depression or anxiety, nulliparity, family history of dysmenorrhea, heavier menstrual flow, lack of social support. What about the pathophysiology? The primary dysmenorrhea is not well understood up till now. However, the identified cause is due to the hypersecretion of prostaglandins from the uterine endometrium. Prostaglandin F2 alpha and the prostaglandin F2 increase the uterine tone and also cause high amplitude contraction of the uterus. On the other side, vasopressin has been linked to primary dysmenorrhea. It causes uterine contractility and ischemic pain due to vasoconstriction effect. The uterine contractility is observed to be more prominent in the first 2 days of the menstrual period. Progesterone levels drop before menstruation, which leads to increased production of prostaglandins, triggering dysmenorrhea. Endometriosis and adenomyosis are the most common causes of secondary dysmenorrhea in premenopausal women. What about the etiology? As regards primary dysmenorrhea, there are many theories trying to explain the etiology, the biochemical one, as I mentioned, prostaglandin F is the main contributor to the cause of dysmenorrhea. At the time of the endometrial shedding, the endometrial cells release prostaglandin F. Okay? The other series is psychological theory. That's why this type of dysmenorrhea is common in unstable personality and over-anxious women and adolescent girls. The third theory, the anatomical theory, included abnormal uterine position and the abnormalities in the shape of the lens of the cervix, and there are many studies about this. This is as regards the etiology of primary dysmenorrhea. What about secondary dysmenorrhea? Secondary dysmenorrhea, as I said before, is related to another pathology. It's caused by another pathology, and this pathology could be endometriosis, which is very common cause for secondary dysmenorrhea. Also, adenomyosis, fibroid, endometrial polyps, PID, cervicitis, pelvic organ prolapse, presence of intrauterine device like copper T380. Okay? So what about the diagnosis? We can approach the diagnosis through the history taking, especially concentrating on the menstrual history, the family history, and the personal history. Menstrual history is important to focus on the association of the symptoms with the timing of menstruation. Is the pain start before menstruation and decrease with starting of the flow after the first day? This is mainly secondary dysmenorrhea, starting few days before because there is congestion in the pelvis, and with the flow of menstruation decreasing the pain. While in primary dysmenorrhea, the pain start few hours before menstrual flow and continue for 1 or 2 days. Okay. Also, history of the location of pain. Is it lower abdomen, radiating to the back or to the side? Its onset, its characteristic. Is it colicky or dull aching? Colicky more with primary dysmenorrhea, dull aching more with secondary or congestive dysmenorrhea. And its duration and any associated symptoms like headache, fatigue, diarrhea, constipation, nausea, irritability, tiredness is very important. What else? For primary dysmenorrhea, the pain is colicky, start a few hours before the flow and the last 4 hours up to 1 to 2 days. Usually the patient is young, around the menarche age, about the age of 15, adolescent age is common. Pain at lower abdomen and in the back and the inner side of the thigh. In cases of primary dysmenorrhea, the associated symptoms include irritability, headache, vomiting, constipation, bloating, frequency of menstruation, diarrhea, tiredness. Physical examination is usually normal. Pelvic examination is not necessary for adolescent and women with characteristic of primary dysmenorrhea, but pelvic examination can be indicated in adolescent and women who have a previously sexually active and when secondary cause is suspected, or if there is lack of response to treatment. So I wanted to search for the cause if she is resistant to treatment also. What about secondary dysmenorrhea? Pain is dull aching in the lower abdomen, occur before the menstrual flow and relieved by the occurrence of the flow. However, in endometriosis, pain usually continue all over the days of the menstruation and after the end of the menstruation also. And maybe the patient tell you in endometriosis that the most painful day is the day after the end of the menstrual flow. So the curve is increasing. This is characteristic for endometriosis really. Usually occurs, secondary dysmenorrhea usually occur in the later half of reproductive period, more commonly above the age of 25 years old. History and physical examination may suggest other pelvic pathology like endometriosis, adenomyosis, PID, or fibroid, or ovarian mass, and so on. The common findings that indicate secondary dysmenorrhea, including older age, more than 25, vaginal discharge, foul odor, or whitish or grayish in color as in PID, associated symptoms like dyspareunia, dysuria, dyschezia, infertility, nodularity, the uterosacral ligament, adnexal mass, tenderness, all these related to endometriosis or maybe non-gynecologic etiology. Also, there may be abnormal bleeding with enlarged symmetrical uterus as in case of adenomyosis, for example, or abnormal bleeding with enlarged asymmetric uterus as in case of multiple uterine fibroid. Or you may find the pelvic mass or pelvic abdominal mass as in case of fibroid, neoplasm, or ovarian cysts. What is the investigation commonly needed? The ultrasound in the evaluation of primary dysmenorrhea has little significance. However, ultrasound can be useful in differentiating secondary dysmenorrhea. Pregnancy test is useful if pregnancy is suggested due to presence of pregnancy symptoms. In the cervical or vaginal swab, in case of sexually transmitted infection or pelvic inflammatory disease, may be needed. Cervical cytology samples to rule out suspected malignancy if there is any signs related to that. MRI or Doppler ultrasonography may be required if there is adenomyosis or torsion adnexy or deep pelvic endometriosis. Laparoscopy may be indicated when all the non-invasive investigations have been carried out and the cause remains unknown and the patient is resistant to treatment. What is the differential diagnosis from gynecologic causes or non-gynecologic causes? Gynecologic conditions like endometriosis, adenomyosis, ovarian and para-ovarian cyst, adnexal torsion, obstruction of the reproductive tract, pelvic inflammatory disease, sexually transmitted infection, Usher-Mann syndrome, endometrial polyps, ectopic pregnancy, and the chronic pelvic pain. While the non-gynecologic conditions include urinary tract infection, interstitial cystitis, irritable bowel syndrome, and musculoskeletal causes related to the abdominal wall muscle or fascia or pelvic and the hip muscles or sacroiliac joint or lumbosacral muscles. What about the treatment? Please look to these pictures. We can divide the treatment into three categories. Baseline intervention, as in these pictures. First tier treatment, as in these three pictures. Second tier treatment, as in this picture. Baseline intervention like modification of lifestyle, like healthy food, like exercise, especially in obese women, like use of heat applied to the lower abdomen, as in this picture. While the first tier treatment, including non-steroidal anti-inflammatory drugs like mefenamic acid, if there is contraindication, I can give paracetamol with caffeine or with short-acting diuretic, or I can use non-steroidal inflammatory drugs, or I can use contraceptive pills, oral or injectable, progestogen Depo-Provera, medroxyprogesterone acetate depot, or combined oral pills. This is the first tier treatment, or other forms of combined contraception like vaginal ring, or skin patch. The second tier treatment, including electric stimulation, peritibial stimulation, as in this picture, to relieve the pain. Also, I can use Leupride injection in a dose 3.7 intramuscular every month for 3 months. Or I can use laparoscopy. I can do laparoscopy for diagnosis and treatment. Or I can do hysteroscopic resection if the case associated with abnormal uterine bleeding and dysmenorrhea is resistant to the previous lines of treatment. Hysteroscopic resection could be solution. So this is the 3 categories of treatment. Let us go through them. This is the first, the baseline treatment, active lifestyle and the balanced diet, supplement with certain vitamins like vitamin E, vitamin B1, vitamin B6. Vitamin D3 can be given in a large dose 5 days before the menses. Then also you can give ginger powder on day 1 to 3 of the menstrual cycle. Exercise, especially in obese women, food supplements, complementary or alternative medicine, plant-based therapy, Chinese medicine, all of this can be used. However, it is not approved yet by FDA. Acupuncture is supported by some studies, but lack active comparison and lack sound methodological techniques. Heat application, as in this picture, to the lower abdomen is effective to relieve dysmenorrhea. In some studies, it was proved to be effective as ibuprofen and was more effective than acetaminophen, which is a paracetamol. Most women find applying heat more cumbersome than taking oral medication, but it has no side effects. Heat therapy may improve the efficacy of other treatment, so can be added to other treatment. Let us go to the next, which is the first tier treatment. First tier treatment include non-steroidal anti-inflammatory drugs like this one, mefenamic acid 500 milligram, or naproxen also can be given. They are working for relief of dysmenorrhea by inhibiting cyclooxygenase enzyme, thereby blocking prostaglandin production. And around 20% of patients with dysmenorrhea don't respond to the treatment, unfortunately, with non-steroidal anti-inflammatory drugs. Can I use COX-2 selective? Yes, I can use COX-2 selective non-steroidal anti-inflammatory drugs. However, it has no advantage over the mefenamic acid. Okay. At the same time, COX-2 has its side effect on the cardiovascular system. Okay. Acetaminophen or paracetamol with caffeine can relieve pain. Also, I can add short-acting diuretics like bamapro, as in this picture. This is acetaminophen with caffeine. This is acetaminophen with short diuretic, bamapro. Okay. Acetaminophen doesn't have adverse gastrointestinal side effect, and this is advantage for acetaminophen being safe on GIT. Combined oral pills, as in this picture, can be given, reported to be effective in reducing dysmenorrhea compared to placebo among adolescents, limiting endometrial lining growth, thus decreasing production of prostaglandin. Low level of prostaglandins are noted in the menstrual fluid of women on oral contraceptive pills. Contraceptive pill users appear to have significantly lower rate of dysmenorrhea and needed less additional analgesics. This is proved by many studies. I can use also as a contraception and as pain relieving for dysmenorrhea the vaginal ring and the transdermal patch. This is a transdermal patch containing both acynyl estradiol and the progestin, and this is vaginal ring containing also both acynyl estradiol and the progestogen. Applied this, the endometrial effect of estrogen progestin contraceptive are similar regardless of the method of delivery. Therefore, the route of administration shouldn't significantly affect the efficacy. This is a progestin-only pills suitable more for patients with secondary dysmenorrhea related to endometriosis, where the effectiveness as a treatment for primary dysmenorrhea is not evident. Progestogen-only pills mainly work by causing atrophy of the endometrial lining and by inhibiting ovulation. An advantage of progestogen-only contraception is that they can safely be used by women for whom contraceptive doses of estrogen are contraindicated. Okay? A major limitation is the unscheduled bleeding associated with progestogen-only pills, the breakthrough bleeding, and so on. Injectable contraception as Depo-Provera, medroxyprogesterone acetate can be given monthly. One likely mechanism is the 50% amenorrhea rate that occurs after 1 year of use as a result of endometrial atrophy. However, return of fertility may be delayed after discontinuation, so women who may want to become pregnant within the next 1 or 2 years are advised to choose a different method. So it can delay the menstruation, can cause amenorrhea for a certain period. So if the patient wants a pregnancy early, so this is not suitable for her because 50% of cases will have amenorrhea. This is the Implanon implantable contraception, single route, etonogestrel, releasing contraceptive. In analysis of 11 clinical trials of women using contraceptive implant, complete resolution was achieved in more than 3/4 of implant recipients, while reported dysmenorrhea prior to implant placement. Levonorgestrel releasing intrauterine device, as in this picture, use of 20 microgram levonorgestrel releasing ID associated with the reduction of dysmenorrhea, in part because of the approximately 20% amenorrhea rate after 1 year of use. Transcontinuous electric nerve stimulation. Now we are in the second tier treatment. We said from the start we have 3 categories. The first, the baseline or the basic therapy, then first tier treatment, then second tier treatment. We are now in the second tier treatment, and the first one in this group is the transcontinuous electric nerve stimulation, as in this picture. You call it, one of them is percutaneous tibial nerve stimulation, as in this picture. The major limitation of percutaneous tibial nerve stimulation is the need for weekly treatment for 12 weeks. So I need 3 months treatment, really. Weekly treatment for 12 weeks in a row. The patient completes the treatment course and then symptoms are reassessed. This non-pharmacologic treatment can be used in addition to non-hormonal or hormonal therapy. This modality also an alternative for patients who cannot or prefer not to use medications. Okay? Is the role of Empiric GnRH analog or antagonist therapy like Luprit, 3.7 milligram. Yes, I can give it monthly for 3 months. The side effect is menopause-like state. This menopause, the Luprit 3.7 injected intramuscular. Also, I can use the 200 microgram intranasal spray, Noforlin. Okay, twice per day. So either I use any of this method, patient with persistent pain and the negative laparoscopy. If laparoscopy is negative and the patient has previously failed both hormonal contraception and the non-steroidal anti-inflammatory drugs, we would try a 3 months course of GnRH agonist analog such as leuprolide or naproxen. Okay, so I have two groups of patients. I can give them empiric GnRH agonist, either those who did laparoscopy and we found nothing was negative, so and the patient still complaining and the other lines of treatment failed, so I can give GnRH agonist. Or patient with persistent dysmenorrhea not responding to the other line of treatment, and this patient don't want to do laparoscopy. Okay, so I wanted to give her a medical treatment. So after the failure of other lines of treatment, and the patient is not suitable for laparoscopy or she refusing laparoscopy, so I can give empiric GnRH agonist treatment. What is the rule of laparoscopy? Patients who don't respond to any of the previous lines of treatment, we are searching for any pathology, maybe subtle endometriosis. For this reason, we offer diagnostic laparoscopy for women with dysmenorrhea who haven't adequate relief after 3 to 6 months of non-steroidal anti-inflammatory drugs and or hormonal contraception. The most common diagnosis is endometriosis as a cause of secondary dysmenorrhea. What if we have a case with refractory dysmenorrhea? All the lines of treatment failed to control dysmenorrhea and the pain is agonizing and the patient and this pain interfere with patient life. Okay, so I can use hysteroscopic resection as in this picture, especially in patients complaining of abnormal bleeding, uterine bleeding also with dysmenorrhea. Also, I can do laparoscopy or laparotomy hysterectomy. So I can do laparoscopic hysterectomy or laparotomy and hysterectomy for patients who completed her family size and she has a refractory dysmenorrhea, not responding to any line of treatment. To be a last line of treatment is hysterectomy, so long as the patient completed her family size. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.